أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear friends, my colleagues and students, I am actually reporting the different X-ray tests after completing my tutorials of clinical radiology, clinical chest radiology. I have till now I have reported actually 9 of them. The 3 or 4 are remaining, and some of my friend has asked why you are reporting. You have to give the homework to the students to do it. Actually, I am resting at the home. I am not going outside for delivering any lecture now. So I am online actually for the different tutorials or different advices are concerned. So I am definitely on the front wheel drive. I am doing it, no problem. And because I have got much experience, you can say, of reporting these X-rays, in comparison with those who are sitting in the room in the radiology department and they are doing the chest X-rays. In Karachi, one of the center, the radiologist who was FRCR, he is the fellow of the radiologist of the Royal College of Radiologists. Very, very knowledgeable person. He said that he has to report these X-rays about 1500 to 2000 per day alone. And there are other people who is helping him. But some of the points should be missed because the clinical data is not available. That's why I have pointed out some mistakes to him and he agreed on it. He said that you are 100% perfect. Definitely you have done well to pick these points. So share my experience now, I'll say. This is the sentence which I can say. Now this is reporting the chest X-ray number 10. A scenario is given. 18-year-old student presented with effort intolerance escalating in 2 years. He was admitted in the tertiary care hospital for the relief of the shortness of the breath thrice in the current month. 3 times he was admitted because of the pulmonary edema, probably. On examination, the temperature was 98 degrees Fahrenheit and pulse was 110 per minute, is bounding pulse. And the pulse was irregular with pulses deficit. This is the character of the pulse. The present, which was present, pulses deficit was present in comparison. And BP was 90 by 36. Look, the pulse pressure. The pulse pressure is definitely low, lower down, although hypotension is there. Important thing is the pulse pressure. The wide difference, you can appreciate it. Now examination again, we got the mid-sternal, there is bulging and all precordium was pulsatile and systolic thrill, you can say, present at all auscultating areas. But on the auscultation, very cautiously, we found that this is a continuous murmur because S1 and S2 was not appreciated at all. But this murmur is very high intensity. It was rough and grumbling in type of a character, like zoom zoom, like this. And it merges with S2. And this was a grade 6 murmur. Means that the murmur can be heard without a stethoscope even. Was present at all over the precordium and in the interscapula area. JP was raised And there is a pedal edema and there is a tender hepatomegaly, which is not written here. And the investigations are done, and their hemoglobin is 12 gram, TLC was 7,600, the ESR was 24, the random blood sugar was 145, and urine RE is only proteinuria is there, protein plus 1, because of the high stress in the body, body in high stress now. It is not written in this, but I have told you these findings. Because it is extempore type of a presentation of mine. I remember this case, and I am presenting. That's why I am presenting in front of you. So this X-ray test was done. There are a lot of findings on electrocardiogram I don't want to discuss. But the thing is, this is not a routine examination. Routine examination is X-ray test. So yield of the X-ray test is much, you cannot imagine it, if you learn properly. Now this is X-ray test PA view. It is a PA view, yes, because the requirement is PA. Vertebral spine is marked by this middle mediastinum very clearly, and supraclavicular fossa are wide enough. It is a frontal projection dominant PA view. This is the correct statement, because it is not written here and here and here the view. You have to consider it yourself, which is the view. When it is AP view, then you cannot comment on the middle mediastinum. You cannot comment the other things. PA view is required. The other requirements are S plus S plus S, that the patient was straight line. Now 1, 2, 3, no, it's a straight line. The neck was tilted here, that's why trachea is moving there. So it is not in the straight line because of something and because of the poor effort of the patient, and he is not cooperative, you can say, or there is something going wrong with this, because this spine is moving like this. Possibly he has got the moderate type of scoliosis. Later on, you can ascertain about it. He had the scoliosis. The clavicles are normal, the shoulder joint, which seems to be normal to me, and the other requirements are the still S plus S. He was standing, first rib, second rib, third rib, fourth rib, fifth rib, sixth rib, seventh, anterior, eighth. He was standing, and hold the breath properly, still, and hold his breath properly. It is not expiratory film, because the bronchovascular markings can be commented on. There is discrete type of the bronchovascular markings. So I was talking about the scapulae, the little medial border is out, it's fine. The first rib, the second rib, third rib, the fourth rib, upper border, lower border, upper border, lower border, very, very, actually the radio opacity is not very quite fine here. The radio texture of because of the costal cartilages, he is a young man. The costal cartilages cannot be visualized properly in the old age, or in the growing age. It can be the ribs, anterior projections can be easily commented on. Anyway, you have to do not the posterior ribs, but the anterior ribs. So first rib, second rib, third rib, all ribs are counted, and the spaces are about 2 to 2.5 centimeter. He is in stress actually, because he has got fat intolerance. Anyway, the spaces are fair enough. You can see no accessory rib was present. and the trachea cannot be commented in this case because the patient was not in the straight line. One line is drawn here, one is drawn here. It is 90 degrees down, it is bending here towards the left side. On the left side definitely it is abnormal because there is 0 degree angle. On the left side 10 degrees towards the right side is normal. Because of the spine which is actually moving like this, scoliotic, and then again there is a curve. So you have to rule out the kyphoscoliosis by your clinical examination or by lateral views. It cannot be commented. About the lungs fields are concerned, they are divided by first rib, second rib, one line is drawn, imaginary line, the third rib and the fourth rib here, draw a line here, upper, right middle, right lower, left upper, left middle and left lower. The two components in these fields are normal. Their aerograms and the bronchovascular marking and their proportion to themselves. Whatever we seen here is that the bronchovascular marking coming out from the hilar. They are coming from the hilar. They are moving out. Here you can see it. They are touching it to the lateral thoracic wall. It means the congestive changes are seen here. Very closely observations you will find here in this case. This thing. These are the linear markings, small linear markings. There are curly B lines are present in this case. The curly A lines on the apex, the upper below divergent, both sides. Here left side is more. Curly C line are central. This is the central lines coming out, and these are the lines linear. They occur because of the congestion of the lymphatics. Very diagnostic if you see with the magnifying glass. These lines are very, very appreciable. The patient actually has got the signs of the pulmonary edema early because he had been treated for it previously. Now again he has come to you with the same thing, the breathlessness. So he is in pulmonary edema although he is on the therapy. Then right upper dome, it is slightly not curved, it's flat one because patient has got effort intolerance. And you see this angle here, it is not very clear, obscured, some fluid might be present. It should be confirmed by the ultrasonography or tapping, pleural tapping. This costophrenic angle is definitely very acute, is normal, although the curve of the dome of the diaphragm is like this, and the cardiophrenic angle is the cardiophrenic angle. Talking about the middle mediastinum, the upper part and the lower part. Now here is the direction which is changing of the right border, the direction of the left border changing here. So I will make a line here and divide it into 4 for the upper part of the middle mediastinum. Talking of the lower part, the size definitely is enlarged. The cardiothoracic ratio is increased. And the apex is moving straight. It is a boot-shaped heart. It is soldier boot heart. Because the apex is transversely placed. Dominant right ventricular enlargement. On the left ventricle is also enlarged because of this curve. This is the curve. But anyway, the right ventricular enlargement is dominant. And talking about the shape, it is an egg-shaped heart, boot-shaped heart, oval. Borders are very, very marked. This border is divided into upper 1/3 and the lower 2/3. Upper 1/3 will represent the left atrium. The lower 2/3 will represent the left ventricle. The right border, upper 1/3 representing the superior vena cava ending in right atrium, and the lower 1/3 representing the inferior vena cava. Here it is parallel with this, and it is representing the inferior vena cava entering into the right atrium. The other 2/3 border of the right side representing the right atrium. Indirectly, actually, it is pushed up because of the enlargement of the right ventricle. So we assume that the right ventricle is enlarged in this case. This is the comment about the size and the shape of the heart. The upper part of the middle mediastinum. Look this. We divide into 4. First one is the ascending aorta, second is the arch of aorta, which is isodense with the spine. Here's something here. This is probably aortic knuckle is very high here. High pressure in this on this side representing here. And this is the second and third representing the arch of aorta. The fourth one, this is one. This is the part which is presenting the pulmonary conus. It is curved and it is slightly prominent. It is coming like this. It's a vascular shadow. So there are signs of the pulmonary hypertension in this case, although not very marked, but they are seen. The hyla, they are seen here. Coming out these, the left hyla is this, the right hyla is this. The size, shape is normal. The size and shape of the right hyla is normal. Upper border, upper branch, lower branch, very, very prominent branches are coming out. And this is the stem of the right hyla. So, inference is the positive finding in this X-ray is that the lung shows the congestive changes, and there are evidence of the curly B lines, upper lobe divergent. And talking about the right dome, because right dome here it is blocked. Minimum fluid is appreciated here in this case. There is evidence of the cardiomegaly. It is predominant right side cardiomegaly. Right ventricular cardiomegaly dominant rather than left ventricular, radiologically speaking. And the upper part of the mediastinum is a small one, size, because of the high pressure. The aorta knuckle is gone up. It is not visualized properly. So the conclusion is this, that this person has been suffering from, with the help of the data, some congenital heart disease. Summing all that is got the continuous murmur and pulsatile chest, even it is heard without a stethoscope, etc. And it got recurrent pulmonary edema. It is a case of the patent ductus arteriosus, PDA. To me, it is congenital heart disease and there are signs of Eisenmenger reaction. Because right ventricular hypertrophy is there, there are signs of the pulmonary hypertension. And the syndrome is called the Eisenmenger syndrome. Any congenital heart disease resulting in the enlargement of the right ventricle or hypertrophy of the right ventricle associated with the pulmonary hypertension is known as Eisenmenger complex. Eisenmenger syndrome. Complex is this enlargement of the heart right side, it is right ventricular hypertrophy and pulmonary conus is prominent, or pulmonary hypertension's evidence is there. So I will go for a further investigation, later view the electrocardiogram, the echocardiogram and the other investigation, UCE, see the renal function, see the liver functions. The liver was enlarged, tender hepatomegaly, I said already. All investigation should be done, ended up as the patent ductus arteriosus. Although it is a congenital heart disease, as the age grows, it becomes more and more and more. The important thing is that when he usually go to the general practitioner, why the general practitioner missed these findings when he was 12 years old or 14 years old. Why he was not referred to the tertiary care? Why? I don't understand this thing. In our country, actually, There is free license given to the medical professionals. Even doctors are practicing, even homeopaths are practicing, even hakims, the harbors are practicing, even dispensers are practicing, even the assistant of dispenser are practicing freely in this country. There is no law. If there is a law, it is not actually applicable. The people have got, independent. They are independent in this session. I don't know what is called independence. This is independence. So the case becomes worsened. Remember, if there is a pulmonary hypertension, and if the pulmonary artery pressure is more than 35 or 40, then the fibrotic changes will occur in the lung and the person will be on the symptomatic therapy. Now this is the case in which case the surgery should be advised. So this case should be referred to the cardiac surgeon to assess this case and for the closure of the patent ductus very easily. In the child is there, for example, the age of infant, you can give the NSAID, strong NSAIDs, like mefenamic acid, like brufen. It will close in 3 to 4 weeks, this PDA, automatically, because of the reaction of the mefenamic acid or ibuprofen. At this age group, you can do the pharmacologically closure of the valves. Nowadays, intravascular surgery can be done to the right side and close it by anything, the ring or the other umbrellas, and there are other options are there to close this PDA. So this is the case which I have presented. I have seen this and I have presented in front of you. I hope that you have enjoyed with my presentation, and my juniors have learned how to assess this case radiologically, clinical radiology. That is why I call the clinical radiology. Inshallah, I will meet again with another 2 to 3 cases which are remaining. I will share with you, and after sharing these 3 or 4 X-rays, I will go for the interpretation of the pulmonary function test, followed by the interpretation of the arterial blood gases. So I hope you will be fine, inshallah ta'ala. I wish you good luck. Assalamu alaikum wa rahmatullahi wa barakatuh. Wa ma alayna illa al-balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.